My dear students, this is the last of the in this series of difficult to treat infections. In the previous two sessions, I have tried to elaborate on a few points about difficult to treat gram-negative infections and difficult to treat gram-positive infections. And in this video, I'm going to give you an outline with some case-based presentations on difficult to treat invasive fungal infections. Let us start with this case. The first case, a case of 62-year-old male post liver transplant on caspofungin for 10 days due to Candida glabrata isolated from the central line. New blood cultures positive again. Patient is febrile, hypotensive on vasopressors. So the key issues in this case are breakthrough fungemia while receiving echinocandin for Candida glabrata, the biofilm, along with persistent intravascular focus. And whenever we have such a situation, we need to think about mutation, and the possible resistant mutations in case of Candida glabrata are FKS1 and FKS2. So these mutations in the FKS1 and FKS2 genes are the primary cause of acquired resistance to all echinocandin antifungal drugs, not just Candida glabrata. It can happen with any other species as well. So we have to know a little bit about this FKS mutant Candida glabrata because the risk factors and outcomes, they have been published many times, and there are a lot of publications in the literature. If you search, you will get it, because to identify the risk factors for echinocandin treatment failure. And these patients in this study, of course, they did not find a lot of differences because the sample size was not that big. But the factors, if you notice, the ones chosen are very important, like GI surgery previous 30 days, total parenteral nutrition previous 30 days, ICU at the time of candidemia, presence of CVC removed within 72 hours, echinocandin exposure before 60 days, and fluconazole exposure previous 60 days. So these have all been studied at various other studies as risk factors, and they tried to group these risk factors together. That is why this study is so important. And if you notice these risk factors, you can clearly see that many of these risk factors are very similar to the risk factors for any invasive fungal infections. So FKS mutant probably occurs only with time, and it can cause breakthrough infection in patients who are already on echinocandin unless the echinocandin is started sufficiently early. So once it is started late, we can have more of these FKS mutants available. And this FKS mutations in Candida glabrata varies among the institutions, ranging between 3% to 18%. So 18% we can imagine is not a less number, because 1 in 5 patients on invasive fungal infections on echinocandin can develop this mutation. So whenever we encounter such a case, we have to go for repeat blood cultures daily, go for an urgent fundoscopy, go for either TTE, or if TTE window is not good or not easily obtainable, or TE may be even help for to exclude fungal endocarditis, remove all intravascular catheters, and send isolate for micafungin or caspofungin MIC along with FKS sequencing, if FKS sequencing is available in the microbiology. And the point I also wish to mention is that fundoscopy, I said, is urgent because it is the primary method to detect ocular candidiasis, which is a serious and potentially sight-threatening complication that occurs in these patients quite often. It has been reported quite often. So treatment algorithm in such patients, we have FKS mutation induced Candida breakthrough infection is to switch the class immediately, to switch to liposomal amphobi 3 to 5 milligrams per kg per day. Consider azole step down only after species identification, confirmation of the susceptibility, and always treat for more than equal to 14 days after the first negative blood culture. So this is important in terms of treating those resistant infections or difficult to treat Candida glabrata as well as for other Candida. So in breakthrough candidemia on echinocandin, we have to assume FKS mutation unless it is proven otherwise. So we should take it into consideration that it is due to FKS mutation. If you see the other literature, the treatment of Candida glabrata infection in immunosuppressed mice, this was the first instance when the animal experiment, after detecting this glabrata, and we were using a combination of amphotericin B with caspofungin or micafungin, it was found that the response was better to micafungin, and after then, since then, micafungin was used for a considerable time, till of course they found that there is no reasonable difference between two in case of Candida glabrata, and breakthrough infection can occur after both caspofungin and micafungin. So once it is there, then we have to switch the class. Recurrent episodes of candidemia due to Candida glabrata, tropicalis, and Candida albicans with acquired echinocandin resistance is also reported, although not that commonly as with others. But yes, it has been reported. And in those cases, also early switching to amphoby is probably helpful. So liposomal amphoby is often reserved as salvage or rescue therapy when the first line therapy fails or when resistance emerges, and this is consistent with expert opinion and review-based guidance. Let us come to case 2. This is a 40-year-old diabetic post-COVID fibrotic lung who presents with hemoptysis, weight loss, and multiple cavities on CT. Serum galactomannan is negative. Bile galactomannan is weakly positive. So, if we have to think of aspergillosis, the problem in this case would be whether it is a true invasive disease or whether it is a saprophytic colonization. Now, there are some diagnostic pearls in these cases, and you have to always choose radiology over serology in confirmation of the diagnosis. In the radiology, you get thick walled cavities, as you can see in this diagram, the white ones, the walls are thick. There is pericavitary infiltrates surrounding the cavity, nodules with halo sign, as you can see, and serum galactomannan low sensitivity is there in chronic disease. So reliability of serum galactomannan is very less. So we will have to depend more on radiology. There are other pitfalls of serum galactomannan also, because use serum galactomannan mainly in high risk or immunocompromised patients, either neutropenic or hematologic malignancies or transplant, especially in suspected acute invasive disease, not otherwise. Do not rely solely on one-time negative serum galactomannan to exclude disease. Repeat testing may help. And in chronic pulmonary forms, negative galactomannan does not exclude infection. And always interpret galactomannan in the context of clinical plus radiological plus microbiological data. And this includes imaging, BAL, sputum culture, PCR, especially when the clinical suspicion is high. And consider complementary assays like beta-2-glucan or BAL-galactomannan for better sensitivity, especially if serum galactomannan is negative, but suspicion is high or suspicion continues to remain after getting the negative report. So serum galactomannan is something which should not be relied upon in patients with chronic pulmonary aspergillosis. The management, of course, the first line is voriconazole. Voriconazole will require therapeutic drug monitoring because a little bit of reduction or increase in the dose can lead to either suboptimal therapy or toxicity. The alternatives are posaconazole and isavuconazole. The duration is 6 to 12 months. One has to reassess radiologically every 8 to 12 weeks about the nature or progress of the disease. Isavuconazole used as salvage therapy in chronic pulmonary fungal disease, including aspergillosis, is tolerated reasonably well and shows role of newer azoles in patients who are either intolerant or resistant to the older azoles. So this is something one can look for when one should try in this kind of patients with aspergillosis. Now let's go to the third case, 25-year-old post-DKA with left facial pain, black nasal eschar, third cranial nerve palsy, the MRI showing cavernous sinus thrombosis. So mucormycosis, as we know, is very common in uncontrolled diabetes, and even in controlled diabetes, because of other complications, they can happen with much more prevalence than non-diabetics. The key problems include the rhizopus mucor, the leishthymia, the angioinvasion, CNS extension, and it carries a very high mortality. And often when these patients are operated, a large part of the airway is also excised, and therefore airway control, everything becomes very important in the post-operative period. So urgent steps are ENT and neurosurgery consult, nasal endoscopic biopsy as soon as possible, and also correct acidosis and stop steroids once they are not, and stop steroids. So the steroids are long-term steroids. We have seen during our COVID days that how these patients developed mucormycosis. The therapy consists of high-dose liposomal amphoby to the tune of 10 milligrams per kg per day in case of CNS involvement, early surgical debridement, and step down after control with either the posaconazole or isavuconazole. Adjuncts can include, if available, are hyperbaric oxygen, and one has to go for strict glucose control, particularly in diabetic patients. Now, surgery is as important as antifungals in mucormycosis because without debridement, drugs alone are grossly inadequate. Coming to case 4, a 68-year-old patient on ventilator with persistent fungemia with Candida auris resistant to fluconazole with elevated MICs to echinocandins. Now, this is the test, Candida auris suggested tested plans, but before that, the challenges are the multi-drug resistant profile, biofilm in multiple devices, and environmental persistence. So if you see both the clinical samples and the surveillance swab, if you follow them along the differential media or the isolation or selective media and follow up with Vitek or BD-Phonix or BioFire, we can get Candida auris, and this Candida auris can be confirmed as culture positive. And across the real-time PCR, we can look for DNA positive Candida auris. The antifungal test can give the reports of 21 days, and one should look for rapid notifications, the hospital facility, infection control, and the public health, because this is very, very, very contagious. So both the surveillance swab and the clinical swabs for the clinical samples for the diagnosis and early reporting are essential and important in patients with Candida auris. The strategic plan for the drug of choice, the first line are the echinocandins. Micafungin is preferred, although other echinocandins have also been found to be efficacious. If elevated MIC or breakthrough infection, then one has to go for liposomal amphotericin B, because for most breakthrough candida infections as well as other infections, we have to depend upon liposomal amphoby. Step down should be none unless clearance is documented with surety. And infection control like daily chlorhexidine bath, terminal room cleaning with hydrogen peroxide vapor, screen contacts in the ICU, remove all lines, dialysis catheters, tracheostomy tubes if feasible. So these are all very important part of the strategy plan. Antifungal choice is second priority to infection control. So this is important. Now, antifungals for the treatment of Candida auris, if you see that other than echinocandins, uh, if you see the amphoby has been found particularly with involvement of the CNS, and same as liposomal amphotericin B is also a preferred alternative, and fluconazole is probably has very high MICs and frequent resistances encountered. So it may not be a good choice. So liposomal amphoby, there are side effects of electrolyte disturbance and kidney injury. So one has to be particularly careful. as in any other cases where liposomal amphoby is treated. So here also, but these patients are more prone because if they're uncontrolled diabetic or having a glucose which is preceded with a ketoacidosis. So in that case also, the side effects of the electrolyte disturbances are very common. So while echinocandins remain the first line, evolving resistance and outbreak dynamics necessitate ongoing surveillance, susceptibility testing, and readiness to shift to therapy or use combination as and when needed. Coming to case 5, this is a 50-year-old renal transplant recipient, severe hypoxemia. BAL is positive for pneumocystis jirovecii by PCR on trimethoprim sulfamethoxazole for 72 hours with worsening renal failure. So the red flags in this case would be steroid exposure, CMV co-infection, and DHPS mutation is suspected in such patients of transplant when they develop BAL positive by Pseudomonas jirovecii. So despite being on trimethoprim sulfamethoxazole. So if we see that there are certain gut dysbiosis, M2 polarization, Zirovecii is influenced by a lot of factors. But when the underlying disease is like rheumatic disease, malignancy, HIV infection, or immunosuppressive agents, the effects are manifold. And that produces some change in the genetic change in this Th1, Th2, for which there is alteration in the balance, and that stimulates the macrophages and produces the response which leads to damage to the lungs and other tissues. So treatment, high dose trimethoprim sulfamethoxazole remains the first line. If it is tolerated, we have to add adjuncts like prednisolone. We gradually taper them after starting them in the usual 1 milligram per kg dose. Primaquine and clindamycin for intolerance if the patient remains intolerant to trimethoprim sulfamethoxazole, and such patients will have a rise in the potassium levels following TMP SMX. Atogacone if the mild disease is there only, so no need to give the other drugs, and consider IV pentamidine if deterioration continues. Although this drug is not being tried, is not available nowadays so much, because earlier it was used as a second line in leishmaniasis, but but this is useful in such patients. So the ICU points which are important, we have to watch for hyperkalemia and AKI from TMP-SMX, and the need for high flow or non-invasive ventilation should be instituted early because these patients slowly deteriorate, so they require prolonged care. Radiological worsening in the first 72 hours is common, and trimethoprim sulfamethoxazole should not be stopped prematurely. So they have to be continued. And we have seen a lot of studies as well as meta-analysis which have compared TMP SMX with others. And it has been seen clearly that TMP SMX at the dose of 15 to 20 milligrams per kg per day of the TMP component remains standard first-line therapy. And also authors have noted that the dose is based on historical practice rather than modern dose finding trials. So modern dose finding trials probably are also required since a lot of time has already elapsed in identifying the true dose of TMP-SMX in concurrence with the currently circulating bugs. So quick summary if we have to make of all the 5 cases that we narrated. When there is breakthrough candida infection, here it is because of glabrata. The first line is liposomal amphoby. Step down with azole only if susceptible, but an important note is to remove the lines. With invasive aspergillosis, the first line is voriconazole. Step down, one can go for isavuconazole, and one has to go for therapeutic drug monitoring. Mucormycosis, high dose liposomal amphoby is the first line, and step down can be done with posaconazole. But the important point to note is that surgery is essential. Candida auris candidemia, the first line is echinocandin. Step down with amphotericin if MICA is high for echinocandins, and we have to think about breakouts. For pneumocystis jaruvuci, then if the trimethoprim sulfamethoxazole is the first line. Step down can be achieved with primaquine plus Clinda, and it requires steroids. Thank you.